Eu vou chamar então para a primeira palestra o Dr. James Cleary, que é médico sênior e instrutor de medicina na Harvard Medical School. James, please.
First, I just want to thank Oncoclínicas for having us down here to Brazil. I have to say, I've just been blown away by how beautiful this is. And I was talking to some of my colleagues earlier. We have these telecons with Oncoclínicas Tuesday, once a month. And I learned more from those telecons than I think the people from Brazil learn from me. The questions they ask are incredible. We hear about HER2 amplified colon cancer patients. So it's really been impressive for us in Boston to see the incredible level of care people here in Brazil get for oncology. So today's talk, I'm going to be talking about stage 2 colon cancer. And I have to say, when I see a stage 2 colon cancer patient in clinic, it's probably one of the hardest consults, probably the hardest consult I have, because it's a gray area, it's a controversial area, and we really don't know exactly whether adjuvant therapy helps or adjuvant therapy doesn't help and who it helps. But in the last year, and the reason I think the people who put this conference together were really smart in choosing this topic, within the last year we've gotten a little more data. There's still more questions than data, but at least we're starting to get more data, which helps. Next slide, please. Here are my disclosures. Next slide. So one of the reasons stage 2 colon cancer is so difficult is the trials we have really have never clearly shown a benefit for adjuvant chemotherapy. So this is the IMPACT-2 consortium of trials. This was 4 trials that failed to show that giving adjuvant chemotherapy to stage 2 colon cancer has any benefit. Next slide. However, there have been some shining lights of optimism, thinking that, yeah, maybe stage 2 colon cancer patients can benefit from adjuvant chemotherapy. And probably the best trial for this is the QUASAR trial that did show a benefit for stage 2 colon cancer. But again, even though this was a positive trial, it showed a very small benefit, really just a 3.6% absolute benefit. Critics of doing adjuvant chemotherapy in stage 2 colon cancer patients point out that the lymph nodes of the patients who went on this trial were very small. In general, patients on the QUASAR trial only had about 6 to 7 lymph nodes removed. So critics of this trial feel like perhaps a lot of them actually were stage 3. But again, this is one positive trial showing that adjuvant chemotherapy could possibly work in stage 2 colon cancer. Next slide. More recently, the MOSAIC trials, and again, stepping back, the MOSAIC trial was the trial that showed that in stage 3 colon cancer, adding oxaliplatin to 5-FU-based chemotherapy is beneficial. In stage 3, it's clear. We should treat these patients with FOLFOX. But in that same trial, when they looked at stage 2 patients, there wasn't a difference. So when you looked at stage 2 colon cancer patients, the group of patients who got 5-FU and the group of patients who got 5-FU oxaliplatin did the same. Next slide. This next slide, though, and this paper came out in 2012, really changed my practice. What this sub-analysis did is it took that same MOSAIC cancer trial, but instead it just looked at the high-risk stage 2 patients. And in looking at the high-risk stage 2 patients, we thought that, okay, maybe adding oxaliplatin doesn't work in stage 2 in general, but probably it will work in the high-risk patients. Well, in this database, in the MOSAIC trial, even the high-risk patients, they did not see a survival benefit when the oxaliplatin was added to the 5-FU. Next slide. So with that MOSAIC trial, people have been trying to put together how do we treat stage 2 colon cancer, because it's a controversial area. And one of the reasons it's so controversial is we think to show such a small 3% benefit that we'd have to do an enormous trial. So it's going to be a controversy that really I don't see going away soon. And so what a lot of groups have done is they put out guidelines on how to approach these patients. And the ASCO guidelines, which are very similar to all the other guidelines such as ESMO, they say really the best thing to do with your stage 2 colon cancer patient is talk to them. Tell them the pros and cons of therapy. You have to explain that chemotherapy can cause side effects, but yeah, there's possibly a 3 to 5% benefit. And then they encourage oncologists to risk stratify their patients and try to identify patients who are high risk, who might benefit more from chemotherapy. Next slide. So again, we're going to be talking a lot about high-risk stage 2 colon cancer today. And just to kind of go over the high-risk features of stage 2 colon cancer, they are perforation, obstruction, lymphovascular invasion, perineural invasion, positive margins, an inadequate number of lymph nodes resected, and poorly differentiated pathology. But the one thing I wanted to point out about the poorly differentiated pathology, as I'm sure you guys are well aware, is the exception to this is MSI high tumors. So 20% of stage 2 colon cancers are MSI high. And what we found is those MSI high patients do extremely well. So when I see a stage 2 MSI high colon cancer patient, I really, really do everything I can not to give them chemotherapy, because really those patients do extremely well. And even more to the point is what studies have shown is that MSI high colon cancer patients don't respond well to single agent 5-FU. So if you have to treat an MSI high stage 2 colon cancer, maybe because they have 4 or 5 high risk features, you really have to use FOLFOX. So again, MSI high tumors, really, I hate giving MSI high cancers adjuvant chemotherapy because it really doesn't seem like they benefit. MSI high stage 2 colon cancer patients adjuvant chemotherapy because it really doesn't think like they benefit or that they need it since they do so well. Next slide. This slide tries to bring home the point that in stage 2 colon cancer, the number of high-risk features dictates how much risk you have. So if you have one high-risk feature, say lymphovascular invasion, that patient's going to do better than a person with 3 high-risk features. So the more high-risk features you have, the worse your prognosis is. Next slide. Oh, yeah, perfect. So in terms of controversies in stage 2 colon cancers, as we've been discussing, the big controversy is which patients, if any, should we treat? In many patients, for example, a patient with T3N0 stage 2 colon cancer with no high-risk features, I don't treat them with adjuvant chemotherapy unless the patient feels very uncomfortable with that. Then the question is, if you are going to treat a patient with stage 2 colon cancer, which chemotherapy should you give? And so in terms of the way I handle that, for the general stage 2 colon cancer with 1 or maybe even 2 high-risk features, my bias is based on the Mosaic cancer trial that showed that even patients with high risk didn't benefit from adding oxaliplatin to 5-FU. My general approach is only to give adjuvant 5-FU or capecitabine. I generally use capecitabine so I don't have to place a port. Then the next controversy, though, is if you are going to give chemotherapy, how long should you give it to? And the reason this controversy has popped up is in ASCO 2018, some really exciting data came out for stage 3 colon cancer, where the IDEA consortium showed that in patients with low-risk stage 3 colon cancer, and those are patients with T1 to T3 tumors or N1 tumors, that giving them 6 months of adjuvant chemotherapy really isn't necessary, that basically with those low-risk stage 3 colon cancer patients, you can get away with 3 months of Xelox. Next slide. So at ASCO this year, ASCO 2019, the IDEA consortium published data on stage 2 colon cancer, and this data was very helpful. Next slide. Again, they did the same trial design as the IDEA consortium for stage 3. They're asking whether 3 months of adjuvant chemotherapy in stage 2 colon cancer is as good as 6 months. And the trial design is as follows. They took patients with high-risk stage 2 colon cancer, and then the investigators had the choice of whether to treat them with FOLFOX or CAPOX. And then they were randomized in a 1-to-1 fashion to either get 3 months of FOLFOX or CAPOX or 6 months of FOLFOX or CAPOX. Now, the one thing I want to point out is what's really interesting in the stage 3 data is that when we treat patients with low-risk stage 3 colon cancer, we can do 3 months of Xelox, but not FOLFOX. And people have been trying to figure this out. Why does Xelox work for 3 months, but not FOLFOX? And the answer is we don't know yet. One possibility is that Xelox, as you know, the regimen is slightly different from FOLFOX. With Zelox, you get oxaliplatin 130 milligrams per meter squared, whereas with Folfox, you get oxaliplatin 85 milligrams per meter squared. Over the length of the treatment, the oxaliplatin dose is the same, but it's just slightly more intense with the Zelox. So that's been one hypothesis. Perhaps by giving a higher dose of oxaliplatin, it works better. The other hypothesis, though, is this. It's that it's investigator choice. And perhaps there's reasons where people are choosing Capox for some patients and Folfox for other patients. And that's why, even though that theory I just said is kind of attractive, a higher dose of oxaliplatin, maybe it works better, it's far from certain. We just don't know because it wasn't really designed to answer that question. So again, going back to stage 2, in this IDEA consortium, there were 4 sites, and if you can see, they all enrolled very well, and these sites were in Europe, Australia, and even a site in Japan, so a multinational effort. And what the statistical design was is they were looking, their primary endpoint was disease-free survival. And again, they recognized that if this works, if adjuvant chemotherapy works in stage 2 colon cancer, it's going to be a very small benefit. So they really powered it to see a 3.1% reduction in 5-year disease-free survival. And they felt like if the hazard ratio is over 1.2, well, that's not good enough. They're non-inferior. Whereas if the hazard ratio is less than 1.2, it was non-inferior, and it would be a good option. Looking at the data, and this is one of the criticisms of this trial, is when you think about high-risk stage 2 colon cancer, it's very heterogeneous. You have some patients with T4B tumors that are perforated, and we all would agree those are high risk. And others that are T3 that maybe have one high-risk feature like lymphovascular invasion, which maybe not as high risk as others. And so on this IDEA consortium, most of the tumors were stage T3. In terms of adverse events, and this is why the IDEA consortium, both in stage 3 colon cancer and stage 2 colon cancer, is so important. As sure as all of you know, it's really tough to do 6 months of adjuvant chemotherapy. The neuropathy that these patients get are horrible. And so this is why these trials have been so valuable, that giving less oxaliplatin really reduces the amount of neuropathy. And that shows it here very clearly that really, when you give 3 months of chemotherapy as opposed to 6, much less neuropathy, but much less of other side effects too. So it really makes it easier on the patients. So when they looked at the data from this trial, when they looked at the data overall, counting the Folfox and the Zelox patients, it was non-inferior, meaning that 3 months wasn't as good as 6 months. However, while looking at all the patients was non-inferior, similar to the stage 3 data, when they separated by regimen, while Folfox was non-inferior, while you wouldn't want to use Folfox in a 3-month setting, you have to use Folfox in a 6-month setting, Capox was non-inferior. So Capox, really 3 months of Capox is the same as 6 months of Capox in a stage 2 setting. So this is a big deal. So really, this gives you justification that if you're treating a patient with stage 2 colon cancer, that it's okay to give them 3 months as opposed to 6 months of therapy. And again, here's our conclusions. That while for the whole trial, when you include the Folfox patients, that they did not show non-inferiority, for the Capox arm, 3 months of Capox is just as good as 6 months of Capox. So here are the criticisms of the IDEA stage 2 trial. The first one is what we talked about before, that for most oncologists, I think when we see a stage 2 colon cancer patient, we usually don't use Folfox or Zelox. We usually just use single agent 5-FU or capecitabine. So this might not really be that practice changing because most people are using single agent capecitabine anyway. The other thing is that high risk stage 2 colon cancer is very diverse. That yes, you can have a patient with a T3 tumor that has lymphovascular invasion, and yeah, those patients are going to do well. But then you can have a patient with T4B cancer that's perforated and presented with an obstruction. You're really worried about them. So it's a very, very diverse population. So how applicable these results are is tough to know. So this stage 2 colon cancer question about when to use chemotherapy and when not to use chemotherapy still is, to be honest, a very open question. we're trying to use these with biomarkers. We're trying to answer this question with biomarkers. And so there is one biomarker that's available, Oncotype DX. It's very similar to what they have in colon cancer. It's a multi-gene panel that can risk stratify which patients with stage 2 colon cancer have a worse prognosis. And their thought is cell-free DNA. And so one of the leaders of stage 2 colon cancer put together this really interesting diagram. And the way she sees stage 2 colon cancer, which I think is very reasonable, is on the right, you'll see for T3 tumors that are MSI high, I think we'd all agree we shouldn't treat them. Whereas in the middle, those are the tough ones. The T3 tumors that are microsatellite stable with no high-risk features. Should we give them chemotherapy or shouldn't we? And that's where she feels like these genomic tests might really help us. And so when they looked at these genomic classifiers, the reason, I'll be honest, I've never used any of these genomic classifiers. The reason why is, yes, it shows which patients are higher risk. However, the shortcoming is it doesn't show that those patients that are higher risk will benefit more from chemotherapy. That hasn't been shown. So the reason I don't routinely use Oncotype DX is I don't think it gives me any information about which patients will benefit from chemotherapy. It only tells me which patients are at higher risk. So then the other thought is, well, maybe we can use cell-free DNA in these patients where we're trying to decide. And that's still an open question, but it's going to be tested. And this is a really interesting trial that's ongoing. We don't know the answer yet, but just to sort of tell you what they're doing, it's called the COBRA trial, and they're using cell-free DNA on patients where you think, well, observation would be reasonable or observation wouldn't be reasonable. So for example, again, that T3N0 patient with lymphovascular invasion. So for a patient like that where you're sort of torn, should I give adjuvant chemotherapy or not, you could enroll them on this trial. And so the patients will be randomized to two approaches. First, some patients will be randomized to observation, which is reasonable. And then other patients will be randomized to using cell-free DNA to help the clinicians decide whether they should give chemotherapy or not. The reason why this trial is going to be so important is this is going to answer the question that not only do patients with cell-free DNA indicative of still having tumor with stage 2 colon cancer have a worse prognosis, it's going to say, if it's a positive trial, that if there's cell-free DNA there, that chemotherapy could help. So it's still an open question, but I think this trial design is really going to help us answer this question. So to conclude, I just wanted to finish up with 3 cases that help you think about at least the way I approach stage 2 colon cancer. In case 1, it's a 50-year-old woman with a T3N0 ascending colon cancer. The cancer is poorly differentiated, but it's MSI high. And as you know, MSI high tumors present as poorly differentiated. So the way I approach this is I do not give this woman any adjuvant chemotherapy because we know that the MSI high tumors do so well. In case 2, I took that same person but made him have more high-risk features. It's now a T4 tumor, poorly differentiated, microsatellite stable, and positive lymphovascular invasion. So for this patient, I would sit down and talk to them about the pros and cons. Again, because I haven't been persuaded that oxaliplatin adds that much, my bias for this patient would be to treat them with 6 months of adjuvant single-agent capecitabine. But again, I'm sure this would be a controversial one, and there's many different answers, and many different ways that this could be approached. And the truth is, I think you really got to talk to the patient about the pros and cons, A, of doing chemotherapy, I think we should, but B, about doing single-agent chemotherapy versus doing combination chemotherapy. If this patient came to me and says, you know what, I'm just not comfortable doing single-agent chemotherapy, I want to do FOLFOX or I want to do XELOX, what I would do for this patient, now knowing the IDEA consortium data, is then I would give 3 months of adjuvant XELOX. In this final case, it's a T4B-N0 50-year-old woman with ascending colon cancer. Again, it's microsatellite stable. But this one really makes me nervous. It's poorly differentiated, presented with perforation. And so when I see a patient like this with so many high-risk features, I do want to give both drugs. I want to not only give chemotherapy, but I want to give a combination regimen. So the way I would treat this patient is I would either give FOLFOX or XELOX. But here's where it's tough. Whereas I really am impressed by the IDEA Consortium's data that 3 months of Zelox is as good as 6 months of Zelox. Here, I kind of feel like this is like it's very similar to a high-risk stage 3 patient. So I would still give 6 months of adjuvant chemotherapy. So for this patient, I would either give 6 months of Folfox or 6 months of Zelox. I would not be comfortable doing 3 months of Zelox. And in the final case, a 67-year-old woman with a T3N0 ascending colon cancer with no high-risk features, an MSS tumor. For this patient, I wouldn't give any adjuvant chemotherapy. Since there's no high-risk features, I would really just say we should do surveillance alone. Thank you very much.